Thank you all for coming. I'm Linda Resnick. I'm the director of the CoStar Center, and on behalf of CoStar and the Executive Committee, I'm very happy to welcome you here. And this is our third Institute on Health Services Research, and our first that's co-sponsored with CLDR, so we're very excited about that. This institute includes speakers from a range of rehabilitation and research disciplines, and I thank you all for being here and for making this day a great success. Fostering cross-disciplinary research collaborations is critically important, particularly at this time. We have many of the same challenges and goals, but we have unique perspectives to share. And I think we're going to learn a lot from each other today. But before we begin, I want to say thank you. First of all, thank you to our funder, the Foundation for Physical Therapy, and thank you to the Medical Rehabilitation Research Resource Network funded by the National Institute of Child Health and Human Development. And I also wanted to say thank you to our sponsors, NaviHealth and the American Occupational Therapy Foundation. And let's have a round of applause for Mary Slavin and Allie Cole and your team for your efforts in making us all so welcome and making things run so smoothly. I want to tell you a little bit about CoStar. CoStar, we're just finishing our third year, beginning our fourth year. And as a center, we fund fellowships, pilot studies, and training opportunities like this institute. And to date, we have funded 7 faculty fellows and 2 postdoctoral fellows. And many of them are here today. And we've also funded 3 visiting scientists. And if you are a CoStar trainee or visiting scientist, please stand so we can acknowledge you and others can see who you are. So this really is the future of health services research and physical therapy. And we're very excited about you and all of the good work that you're doing and the future work that you're going to do as we follow your careers. We'll be announcing our 4th-year fellows very soon, and we have some unique collaborations this year, which we're excited to tell you more about when the announcements are ready. So look for that in the next few weeks. CoStar has funded 10 pilot studies to date. And last night at the poster session, I think we saw 3 or 4 posters that were directly related to CoStar pilot work. And if you are a CoStar pilot study recipient, please stand so people can recognize you. We expect to fund additional pilot studies this year, and we'll be putting out our RFA this spring for the next call for pilot studies. So during our institute today, we're going to learn about initiatives and priorities related to the quality strategy and the national quality strategy. And CMS has several goals for the National Quality Strategy, which we'll be learning about in depth. But first, to tie Medicare payments to value and quality through alternative payment models, and the second, to tie fee-for-service payment to quality or value. So these initiatives are basically reshaping the way care is delivered and financed, and they raise critical questions for our consideration. So I'll highlight a few of them. What is quality and value? What are the best methods to evaluate quality and value? And whose responsibility is it to evaluate quality and value? And how do we promote value? So these questions, in my view, are research questions. These are questions that cannot be answered without health services research. The answers to these questions require a firm foundation in understanding the healthcare landscape and context. They require good study design, robust data sources, sound approaches to data analyses, as well as strategies to disseminate and implement findings. These questions can only be asked and answered by savvy investigators who have the content expertise and skills to conduct the research. And I believe that we have assembled such a group here today at this institute with many investigators and trainees who are really well poised to conduct this work and are conducting this work. So my hope is that this year's institute will deepen your understanding of health services research approaches to study quality and expand your professional networks and further your work. So please take the opportunity today to meet each other, talk about your work, and really think about the next steps in your own professional journey. So I invite you to enjoy the day, and I'd like to ask Ken to come up and make a few remarks.
Well, good morning, everyone. Thank you for being here. I'd like to begin first by thanking Linda and the leadership of CoStar for the opportunity to be here, to be part of this institute. This is really, as Linda mentioned, in terms of the focus of the talks today and the changes that are happening in healthcare, particularly in our world, in post-acute care. I'm one of those folks who's been around for a while, and this is probably the most exciting time that I can think of in terms of my career for folks who are doing things related to health services and large data investigations. So this is really an opportunity. I want to, before I make a couple of other comments, but just to tell you a little bit about our center. Our center, the CLDR, is really the Center for Large Data Research and Data Sharing in Rehabilitation. And this is an infrastructure grant. It's a P2C grant that's funded by the NIH. And we've had this, we're in the second cycle of this grant. The grant was first funded in 2010. And I can tell you in 2010, when we started telling people that we wanted to help them to do health services related research, particularly to do research with large data and to do secondary data analysis, we kind of had to go around and visit people and really convince them that this was worth doing. Because it wasn't the kind of thing that most rehabilitation professionals did. Most of us, certainly when I did my graduate training, my training was, in terms of doing research, was to learn how to do prospective, patient-oriented clinical research, because we're clinical fields and that's what we should know how to do. But there are now opportunities to answer some really important clinical questions with these large data sets and through health services types of research. So we also have our program that helps to build research capacity, and that includes pilot projects and a visiting scholar program. So we're in the process right now of awarding our, I guess it's our third cycle of pilot projects for this cycle of the grant. So we really encourage you all to take advantage of the resources that we have, to go to our website and visit the website. Our grant is a consortium. It's the University of Texas Medical Branch. It also involves the University of Michigan and the folks at ICPSR and the Department of Rehab Medicine at the University of Michigan and the folks at Cornell University. And we all have different components that we're responsible for within the mission of the center. And I also want to thank Mary and Allison for their organization in putting this together. They've just been wonderful in terms of organizing the speakers and identifying people and just doing all of the things that make it possible for us to be here this morning. But I do want to recognize a couple of the folks at the CLDR, Matt Lockich. Matt's hiding in the back there, and Matt is the research coordinator for our grant and helps make everything run. And Beth Cameron, who's not here, but some of you who have worked with us in our programs are familiar with Beth. She's our administrative assistant and our administrative manager. She wouldn't want to be called an assistant. Our administrative manager in Galveston. I also have the pleasure to introduce our speaker today, our first speaker. And Gerben de Jong is probably the best person I could think of to do the introductory talk at this institute. You know, the title of the institute is Quality Strategies in Rehabilitation, Advancing Health Service Research. For some of us in the room, being part of health service research is relatively new. This is kind of a new area for us. It's not a new area for Dr. DeYoung. Dr. DeYoung has been one of the go-to, or probably the go-to person in rehabilitation and medical rehabilitation for the last 30 years if you wanted to know something about health policy or health services research. And we're delighted that he's here today to introduce the symposium and the topics. And Dr. DeYoung is, I'm going to give you a little bit of his background. He's a senior fellow for health policy and post-acute care at MedStar National Rehabilitation Network in Washington, D.C. He's professor in the Department of Rehabilitation Medicine at Georgetown University School of Medicine, and he's senior partner of Delta Med Partners. And we're delighted that he's here. And Gerben, welcome.
Thank you, Ken. Thank you, Ken. And thank you, everyone. And I thank the sponsors and the organizers for inviting me here today. It's been a great opportunity to come here. I guess in some ways, this gathering is something like a 30-year dream come true, because 30 years ago, we had a conference something like this. Back in the late 80s, I think it was 1988 or so, we had a grant from the Robert Wood Johnson Foundation about health services research and disability and rehabilitation. And I'll have to tell you, it's been a 30-year struggle just to get the traction to bring health services research to this field, because I always have felt it had a lot to offer, but was not always appreciated. And to see some of the posters that I've seen and to see how this area has evolved, especially in the last several years, it's amazing and I think professionally very gratifying. And I'm just pleased that I've lived long enough in my professional career to see this all happen. So thank you very much. And I also want to thank the host and the sponsors. I really like the foundation for PT's byline there, funding research to optimize movement and health. I like that, movement and health. And I'll get to that a little bit more later in my presentation. Again, I'd like to acknowledge both Allison Cole and Mary Slavin. Mary and I go way back. And I've always appreciated all the things that she does behind the scenes. She keeps a very low profile, but she's right there all the time. Also, I want to acknowledge some of my colleagues from the last 30 years. I think not only Ken Ottenbacher, who introduced me, but Vince Moore and I went to graduate school together back in the 1970s. And then also Alan Jetty and I think our first paper that we collaborated on was, I think, in the late 70s with Bill O'Neill, as you may recall, a cardiologist, and we did some work on cardiac rehab outcomes way back then. Anyway, I also like to acknowledge Debbie Reber, who's a clinical vice president with Brooks Health, Brooks Rehabilitation in Jacksonville, Florida. She was one of the main sources for updating my profile on the Brooks Health System, which I'll be talking about a little bit later as a bit of a case study of what's going on in this field. I also want to extend greetings from my home base, MedStar's National Rehabilitation Hospital. This is what the hospital looks like right about now, this time of the year. And also from Georgetown University in the Department of Rehab Medicine. And also, I'm a principal with Delta Med Partners. We are a post-acute data analytics firm and also doing post-acute facility development in Asia, particularly in China. And the hospital that you see off to the right is a rendering of a hospital that is now going to be coming out of the ground as of this month. And for those of you who want to work in Asia or do work there, believe me, we're looking for clinicians, clinical leaders, and also great people who are great in data analytics and health services research. So I'll put in my plug right there. Please see me afterwards. All right. Okay, today's roadmap. We're going to do mainly three things. First of all, I just want to characterize our nation's journey to value-based healthcare. Where have we been? Where are we going? How is this all evolving? How is it all converging? Then I want to talk about data analytics and health services research a little bit, and then what does it take to become a smart clinician in a value-based world? Okay, now, a lot of what happens in healthcare reform We talk often of healthcare reform, but I like to break it up into two parts, what I call front stage and backstage. Front stage reform is what's visible to the public. It's about health insurance products, health insurance exchanges, the subsidies, both direct and indirect, that we hear about all the time. This is what people refer to as Obamacare. All right. But also in the ACA, backstage, largely invisible to the public, is this whole movement toward value-based healthcare. It's seen by health plans and providers, and it deals a lot with how health plans and providers are paid. But this is something that's ongoing, it's very durable, and actually in some ways preceded the ACA. And what a lot of people don't appreciate is, I should probably go back one slide, how much of this is invisible to the public, particularly if you take that iceberg picture that you see at the bottom here. What I think is interesting, most of the interesting activity is below the waterline, unknown and invisible to most people. Okay, one way I like to characterize our journey to value-based care is to look at where we started and where we are or where we have been. Now, I don't hear very many health economists say this, but my original training was in economics. I don't consider myself an economist. I don't consider myself a health economist. But, we're all victims of our own training. And once you're trained in a certain way, you look at the world in a certain way. So when I look at healthcare, I often look at it from the standpoint of markets. I'm really attuned to what kinds of markets are functional, dysfunctional, and what makes markets work and not work. So one of the ways I would characterize healthcare markets is that healthcare markets historically have not competed on price and quality, but on risk and prestige. Okay? And how does that happen? How does that work? Well, health plans win by making sure they do not over-enroll high-risk subscribers. It's the whole issue of averting adverse risk selection. So risk selection is a big issue. Providers do it to a certain extent too, because if you're in a for-profit system and you're really concerned about your margins, you want to make sure you don't over-enroll or over-invite, so to speak, really high-risk patients on which you may lose money. And also, you see this everywhere where health plans compete. And with the problem with prestige competition is the fact that when we compete on prestige competition, in my view, escalates cost. So let's look at the way prestige competition plays out in healthcare for a moment. You look at both healthcare and the other industry where we see a lot of prestige competition is in higher education. All right? Take a look at these two lists. They're virtually the same, okay? We like to compete on our rankings in the U.S. News and World Report, our specialties, our individual departments, whether or not we have the latest GWES technology, latest imaging technology, the latest in robotic surgery, or the latest in whatever it is that we want. We like to brag about our research portfolios, about the amount of NIH funding we have, and to the extent to which we publish in JAMA and New England Journal of Medicine rather than these other so-called rinky-dink journals that people think about. Okay, I'm being facetious here, of course. All right? And people underestimate what really goes on apart from those other those journals. But also, we do a lot of competition on amenities. There's a huge amenities race going on in healthcare right now. Look at our healthcare facilities today. You walk in, the beautiful lobbies, the beautiful settings, or for that matter, when you go to universities and college campuses, it's also amazing to see all the amenities that are now available. In fact, there's an amenities arms race going on. And these are 3 quotes that I have here that you see on the screen. And what's interesting, each one of these refers to an amenities arms race that's underway. All right? And this article from the LA Times back in 2015 said, for the last decade, colleges across the U.S. have been trickling out campuses to compete in an amenities arms race aimed at attracting prospective freshmen. Free tanning, boulder caves, bouldering caves, gourmet dining, and luxury fitness centers are not uncommon, all right? So that's the kind of arms race that we've had in higher education. It's one of the reasons why costs have increased so much in higher education. All right, now it's also true in healthcare. Now I just used this one ad. I was on a flight once from either Dallas or from Houston down to Corpus Christi to give a talk on healthcare reform a few years back. I came across this ad in In-Flight magazine where Memorial Hermann was bragging about its amenities. It says, we have unmatched medical innovation and technology. Here, the innovation and technology, see that? Okay. Affiliated with UT Medical School, okay. Patient amenities, most modern of its kind in Texas. Breakthroughs every day. All right, look at that. Okay. You've seen these over and over and over again. It's classic prestige competition. Now, I don't want to disparage Memorial Hermann. It's probably a very good system, all right? But I'm going to tell you, I've been part of a system that does the same thing. All of our systems do that. And that leads to a kind of an arms race in healthcare. All right? But are we really getting value? Are we really getting good outcomes for the amount of money we spend? Well, look at some of these international comparisons. This is from 2014, actually from 1970 to 2014. Look at that bottom line there, USA. All right, we spend an average of about $9,000 per person per year on health care, and our life expectancy is around 79 years. Think about that. Now, look at another country. This thing is not working very well. Look at Spain, near the top over there. All right, Spain, life expectancy at about 83 years, but spends 1/3, okay, as much as we do per person on health care. So which of these two countries are getting more value for their dollar or for their whatever currency? In the case of Spain, it'd be euro, of course. But the point is that we are not getting the value for our dollar in health care or the outcomes that we want. And this is one of the reasons that really pushed all the Backstage reform that you see in the Affordable Care Act. All right, so the Backstage transitions are many, going from a system that we've currently had where we paid for inputs using fee-for-service, and where the more volume we produced, the more we got paid, where providers didn't really have any risk, so to speak. And we were rewarded for using higher cost settings, and also it really jet fueled the whole prestige competition that we've seen in healthcare over the last, at least my lifetime. All right. And then we're moving toward a system where we're going to pay more based on population, using capitation. We're going to pay for value, where providers are going to not only partial risk, but maybe even full risk, okay? Moving patients from lower cost settings to, from higher cost settings to lower cost settings, and we're moving from prestige competition to price and quality competition. And in between, we also have all these other payment mechanisms that I'm going to be sharing with you in a moment. Okay, in a sense, we're having two sets of reforms that are going on concurrently. One is the development of quality metrics, all right, and the other is payment reform. Because if value is outcomes divided by cost, we have to address both the cost side vis-a-vis payment, okay, and we also have to address the quality side, all right? So it's really two tracks, and when these two tracks converge, where we pay directly for quality, that's where the value proposition is created, okay? It's the convergence of payment reform and quality metrics that really enables us to achieve a value-based healthcare system. I like this one here. Tell me how you're going to pay me, and I'm going to tell you how I'm going to practice, all right? And I'm going to illustrate that a little bit later on in this presentation. Now, I'm going to just talk at a higher level for a moment, and then I'll drill down a little bit, but not too much. Okay, Sylvia Burwell, back about 3 years ago, 2015, basically said we're going to link more payment to quality, especially through the use of alternative payment models such as ACOs and bundled payment, and that by end of 2018, like to see 50% of all Medicare payment be in one of these alternative payment models. And for the rest who are still in fee-for-service, by 90%, payment will somehow or another be linked to outcome in the fee-for-service system. So that's what she said, and that was the track that we've been on, or we were on, that she wanted to achieve. Well, then, of course, we have this new administration that came in with the last election. And it looked like Tom Price was going to really pedal back on all of this. He was an orthopedic surgeon who hated bundled payment, who hated the ACA, and anything that had come out of the previous administration. And so it was very clear, he was on a real mission to try to dismantle much of this. And so it was really confusing how much of this backstage reform was going to continue. Well, as you know, he didn't last too long in that position. And now we have a new HH secretary, Alex Azar, and it's really interesting. He made a speech just a month ago today to the Federation of American Hospitals, that's the for-profit hospital system in this country, and really doubling down on the journey toward value-based payment. He said, value-based payment is still far from reaching its potential. For over a decade, we have been on a journey to replace that equation, that is paying for procedures, with a new one, paying for outcomes and wellness, but that transition needs to accelerate dramatically. All right, so he's going to double down on the backstage reform that was in Obamacare, so to speak. If you want to look at a backdoor, shall we say, endorsement of backstage reform of the ACA, this is a remarkable endorsement, in my opinion. It says, upon taking office at HHS, I identified value-based transformations of our entire healthcare system as one of the top 4 priorities for our department. He says, I don't intend to spend the next several years tinkering with how to build the very best joint replacement bundle. We want to look at bold measures where value is rewarded handsomely. Well, that's a pretty clear message, and saying this to the for-profit healthcare industry, that is really, I think, a statement in itself. So it's going to be interesting to see where we go forward at this point. Now, let's take a broader view just for a moment. We've been on this journey for quite a while. In some ways, I think it started with the Deficit Reduction Act, which really authorized the development of the care tool and the care item set, so to speak. And then the ACA came along in 2010. Then we had PAMA in 2014. Then the Impact Act also of 2014, with which many of you are already familiar, and I don't need to say a whole lot about that. And then MACRA, which replaced the Sustainable Growth Formula for physician payment. And all of these things are converging on value-based payment in one way or another, all right? So what's really interesting to see is how PAMA, Impact Act, and MACRA, which has a lot of Republican support and was voted and has a strong Republican imprimatur, is really a lot of that's the endorsement, as I said again, of what was backstage reform under the ACA. So in other words, there's a lot of bipartisan support for this. So I really think this aspect of our healthcare system moving toward value-based payment is going to be very, very durable. All right. Now, I'm just going to use a few examples. This is in the fee-for-service part, not alternative payment models, okay? Because really, right now, we're moving on 2 tracks. One is moving toward alternative payment models, such as ACOs and bundled payment. And the other one, for those that are still in fee-for-service, is to link some part of the fee-for-service payment to quality, all right? So I'm now talking about that second part that I just mentioned here. And so hospitals, for example, are going to have some part of their total payment based on their quality, on their outcomes and quality performance on these different dimensions that you see here on this slide here. And I'm not going to go through all that. I think you can see that for yourselves. All right, and then in the Impact Act, we have a number of quality measures and resource use measures that were authorized by the Act, and these are now going through various stages of development with more and more, and by 2018, we're going to have a lot of public reporting on a number of these different metrics, and eventually, both LTACs and HHAs, as well as IRFs and SNFs, are going to be doing public reporting in this area. All right. Now, the merit-based incentive payments and the MIPS under MACRA is an interesting study or interesting piece of legislation by itself. Recall that it repeals the sustainable growth formula, the SGR, which I won't get into, but basically every few years we had a big crisis because physician payments were going to be cut because suddenly what happened is that it violated the adjustments needed would violate the sustainable growth formula. We're not going to go into that. But the point was, this was the big compromise that came out of it, and said physician payment in the future, to some extent, would be linked to outcome and really having more value-based payment baked in. Now, if you look closely at this, I'm going to the next slide here. In 2019, you can get a 4% bonus, or you're going to lose 4% on your physician payment. And that win or loss is going to increase over the next few years, where there's you can have as much as a 9% upside or as much as a 9% downside. Now that's an 18-point gap from top to bottom, so to speak. Now that, to me, is going to be some pretty powerful incentive in terms of shaping physician behavior. However, it's also, I want to underscore, if you read the last MedPAC report, or no, it was not in the report, they did issued a special brief for invited statement on this for a whole lot of reasons, and I think good reasons. MedPAC believes that the way this is structured is not good, and has recommended, in fact, that MIPS be repealed. So you may want to look at that. So that's a separate discussion. We don't need to get into it. But I think this clearly conveys the intent that providers are going to go at greater risk, both upside and downside risk, for outcomes and for quality. All right. Now, how many of you are familiar with ACOs? All right. How many with APMs? I mean, not with bundled payment. All right. Not everybody. Okay, I'm just going to do just a capsule, if you will, so that we're all on the same page and have the same frame of reference. Okay. All right. All right. Bundled payment systems is the difference between ACO and bundled payment is basically this. Bundled payment is paying for an episode of care, usually a 90-day episode, starting with the index admission or admission to an acute care and hospital, and then for 90 days, or maybe 60 days, or maybe 30 days, but typically 90 days is the episode window that we're talking about. An ACO is providing payment for an entire population. An ACO is where a health system is going to be accountable for the health of a population, or some subpopulation, or whatever the case may be. So it's a population-based model, whereas bundled payment is an episode-based model. All right. Now, they both have the same kinds of objectives, but in any event, I just also want, before I go anywhere else, I want to say that if you're going to have a good population-based strategy like an ACO, you also need a good episode-based management strategy too. Because if you're going to be responsible for a population, what are going to be your two big cost items or your two big cost tickets? It's going to be when someone's admitted to a hospital, okay, and for that episode of care, and also those patients in a population that are particularly high risk. So that's where the big dollars are. So if you're going to do effective if you're going to have an effective ACO, you also need a good episode-based management strategy as well. So these two things are not incompatible or anything like that. In fact, they're reinforcing in many ways. But it's two different kind of, shall we say, prospective payment models. All right. I'm not going to go into all the details, about bundle payment. The first bundle payment efforts on a large scale were rolled out a few years ago. But for the most part, the various people or various health systems that are participating in bundle payment are participating either in what we call Model 2 or Model 3. And Model 2 includes both acute and post-acute care, whereas Model 3 is post-acute only. And notice the word retrospective. What's happening is we're still using the Medicare Fee-for-Service system for payment, and all the providers in that system will have payment based on the fee-for-service system that we've had, but there's an end-of-the-year reconciliation where that payment is redistributed across the providers based on various performance metrics. Okay. Eventually what we're going to be doing is moving entirely over to Model 4, where we have prospective, is that acute care stay on? No, we have both what I see is prospective acute and post-acute care. So that's where I think we're eventually going to be moving toward, and I'm surprised we haven't moved there faster than what we have. Okay, there are more than 2,000 participants in bundle payment. And one of the biggest bundle payment programs is CJR, Comprehensive Joint Replacement, which initially was to be in 67 markets, and then later on under Tom Price's regime, it was reduced to 34 markets. Now it's estimated about 470 hospitals are participating, and will probably involve about 12% of lower extremity joint replacements, 12% of all hips and knees. All right, it started in 2016, going for a 5-year period, and those DRGs rather, 469 and 470. And you can see the original 67 markets that were chosen. Which of these markets are still going to continue in the program, I don't know. What's different about CJR relative to other bundle payment programs, CJR is mandatory. You have to participate. One of the things I like about making it mandatory, you avoid some of the self-selection issues if you're going to do comparisons and look at how CJR or how bundle payment for joint replacement compares with fee-for-service joint replacement. And they've knocked out it's now more voluntary, it's not mandatory. And so what's going to happen, I think, is going to dilute some of the research benefits from evaluating the Comprehensive Joint Replacement Program, the CJR program. So we'll see how that plays out. All right. Now, CJR was one of 3 original mandatory bundles that also included CABGs and also AMIs, acute myocardial infarct, and these are no longer mandatory. In fact, these 2 have been canceled under Tom Price. It'd be interesting to see whether or not they're going to come back to life again under Secretary Azar. I just don't know. All right. And again, CJR includes all Part A and Part B spending. All right. And CMS, as I suggested earlier, continues to make fee-for-service payment. And there's an assessment of spending at the end of the year. The hospitals have to achieve 3% savings. Those hospitals that beat the savings target are then eligible for a bonus. That's the upside risk. And hospitals that go over spending target repay the difference and downside risk. But CMS lowers the savings target for hospitals scoring well on complications and on the HCAHPS. That's the patient experience or patient satisfaction measure. All right. It also allows for gain sharing with physicians, PAC providers, etc. Because if you have a bundle payment and you're going to redistribute the payment based on outcomes and reducing the cost, you then are going to have some type of method of rewarding all the actors in the bundle so that those that reduce cost and also get good outcomes are going to be rewarded more than those who do not. All right. It also provides for greater flexibility. For example, it now allows payment for patient transportation, medical monitoring at home, which might not otherwise have been available. And it also waives the 3-day inpatient stay requirement for SNFs. Now, joint replacements are pretty easy to do in terms of developing a bundled payment, because the costs are pretty predictable. It's a planned admission, and if you were to look at 100 or maybe 1,000 joint replacement patients and look at their cost profile, there are not that many outliers when you look at it. It's fairly predictable. So, as a matter of fact, joint replacement is the most common bundle payment scheme that's out there right now. And it's fairly easy. And this is why Azar says we're not going to keep tinkering with how to come up with the best joint replacement bundle. We need to go beyond that and also deal more difficult kinds of diagnosis that involved unplanned admissions. All right, under the CGR, these are some of the metrics for quality scoring. Again, it's HCAHPS, which is the patient satisfaction measure, the complication rate, and also patient-reported outcomes. Now, if we're going to have a value-based healthcare system, then we also need to have a number of elements or a number of building blocks. So I want to just briefly mention what I think are the 9 building blocks of a value-based healthcare system, and which of these building blocks requires significant health services research contribution or entails a significant HSR component. And now the valances that you see there in the slide, the various check marks, those are my valances. You may have a different assessment of what it should be. You say, well, I know I'd give this one more and this one that one less. We won't argue too much about that, and I think we all have good reasons for what we might think. If we do have a value-based healthcare system, you need an integrated provider network. Whether all the elements are owned by one entity, or whether it's through contractual arrangements, or through some kind of other collaboration, that's another matter. All right, you need to have a well-understood value proposition. All right, you need to have, I'm going to get to 3 in a moment, you need good quality measures and metrics for measuring outcome, patient outcome, patient safety, and patient experience. That's the triad of healthcare quality. All right, just those 3 things, in my view. That's another discussion. All right, and then another key element is care coordination, clinical pathways, and care management strategies. Without that, you don't have an integrated healthcare system. All right, then you also need payment and gain sharing methods for cost and quality across the different actors in the system. You need risk adjustment methods for both payment and outcome. You need an IS and IT strategy for patient monitoring. And you also need a data analytics and predictive modeling capability. Without that, you don't have anything. Because unless you have the data analytics and you have the health services research that go with it, you really cannot have an effective value-based healthcare system. And I'm going to tell you that the analytics and the health services research is absolutely critical to creating a value-based healthcare system. All right. And you need that to create, really, you need those analytics to create feedback loops so that all the actors can then plan, place, and track patients, improve and reward clinical performance, manage risk and readmission risk, create accountability, evaluate outcomes and cost, and also to detect gaming that might go on, all right? So you have to do a little forensic analysis as well, perhaps, all right? And most of this starts, when you do, for example, an episode-based payment system, such as bundle payment, it really starts looking at episode pattern analysis using claims data to identify existing pathways and how they can be improved. All right, it's also important to geographic analysis. You need to know where your patients come from. You need to know how to strategically place your facilities and your equipment, who you're going to partner with geographically. All right, so that's really important. It's also really important to a system's transparency, sense of fairness, and stakeholder buy-in. And also in the future, I see it's really important for harvesting real-time data to track patient progress, and I'll say more about that as well. So when we do the data analytics, I'm going to oversimplify here a little bit. There are really 2 levels of data. Level 1 is what I call higher level data. Level 2 is more granular. At level 1, we're looking at the level of a care pathway, looking across care settings. It's really needed for system planning and for care coordination. Claims data, for example, would be a classic source. And this is usually associated with health services research in one way or another. Then there's what I call level 2, which is more of data that's at the bedside or in the gym. It looks more at data within a care setting. All right, it's needed for daily patient management. It's a lot more granular and more likely to be found, for example, in an electronic medical record. All right, this is what we usually associate with clinical level research. All right, it's really, in my view, is that what value-based healthcare is doing is forcing us to merge these two levels of data and integrate them much more than they have. Now, of course, we've already done a lot of that to a certain extent, but this really underscores the importance. And it's not just not just having the data, it's also having the data analytics. That's what makes smart data, all right? And when we use linked data, all right, with data analytics, we have even smarter data. What do I mean by linked data? I mean linked, for example, the two levels of care data, or linking cost data with outcome data. It's when you link data and mesh data together, along with the analytics, you get even smarter data, all right? And then when you link data and data analytics and use the power of health services research and the thinking of health services research, you have even smarter data. So I think this is the world we're moving into. Now, we also need to have this in order to become smart clinicians. I would argue that in a value-based world, the clinician needs to ask, how do I add value with every patient encounter? But to do so, you have to ask, I need to know where the patient is in his or her functional recovery process. How is the patient trending on several different dimensions? And I need feedback on how well the patient is doing. Now, it's a little bit like, without data, in my view, it's a little bit like flying an airplane without an instrument panel. All right. And so in a sense, if I'm going to be a more efficient and cost-effective, you have to ask the question, how can I accelerate this progress, this process? What steps or interventions are useful? Which ones do not add value and should therefore be eliminated? But I also need to look and think about the patient's longer-term trajectory. What is the patient's next level of care? Is it home? Is it outpatient? How fast can I get the patient there? Here's my argument, is that if you want to look at dealing with a patient in that particular setting of care, you really also have to think about the patient's long-term trajectory. All right, you've got to put those two ideas together and not just for that moment that you have in that one encounter. All right, we can ask the question, for example, if we can keep the patient for an extra 2 days, can we skip the next level of care and send the patient home without any other intermediate step, all right? And more important, I think, you want to know what's happened to other patients like him or her, because that's what gives you the comparative data with which to make good informed decisions. Today, it's all about becoming a smart clinician. Now it's smart everything. Smartphones, smart homes, smart cars, smart TVs, smart thermostats. I can check my thermostat in Naples, Florida right now, right from my iPhone here, okay? Smart buildings, smart cities, smart whiteboards, all right? You could put some smart whiteboard in every patient room if you wanted to, which would be great to do in my opinion. We even have smart refrigerators, see? All right. And, but the key to becoming a smart clinician is having daily or real-time data on the patient's status and progress. Mere clinical observation, in my opinion, is simply not important. It is important, but is not enough. And to become truly smart clinicians, we need smart data at the bedside and in the gym, and for patients to be and also very important for patients to be fully engaged, because patients need daily feedback on how well they are doing. All right, they need to see how they are doing relative to other patients like themselves. And now today we have far better data visualization techniques. All right. And which I think is really a godsend in terms of our ability to communicate with patients and to communicate with each other. And mobile technologies make this more possible than ever before. All right? Now, I just want to say for a moment, you know, when a patient goes into a hospital and with an acute condition, we hook that patient up to a monitor. We monitor everything. You know, the body temperature, pulse rate, respiration rate, blood pressure, pain, okay? We do all of that, and we have all of that continuous. What we don't have continuous information about is about their function, their movement, their motion, their walking speed. And I believe we need to start thinking about how we can begin to passively monitor patients for movement and motion, all right? And how we can tie that in with a patient's functional status score. You know, most functional assessment instruments require clinical observation and manual input of data, or require some patient self-report. So it requires documentation, if you will. All right, and I believe we need to explore, develop, and apply the growing field of the wearable biomonitoring technologies that enable one to passively record patient movement and motion. Functional monitoring, I believe, and assessment should not be intermittent at admission, discharge, and follow-up. That's what we do, admission, discharge, and follow-up. But what about all that time in between? All right, we need continuous feedback to the staff and to the patient and how well they are doing on these dimensions. And we need to think about movement and motion, or whether it's walking speed or something else, as maybe the 5th or 6th vital sign that we should be learning, because that's really what it's all about. And we also need to make sure that whatever biometric device we use can link up easily with the patient's electronic medical record. All right, now I'm also going to say too that we don't necessarily need to have every functional data point, because many of the data points are probably already correlated in one way or another. And the ability to perform one activity often is strongly associated with one's ability to perform other less demanding activities. That's the science behind, for example, the AMPAC, which you are all familiar. All right, and now, I'm just going to do we're running out of time, aren't we? Okay. I'm just going to do a quick study on the Brooks Rehab system in Jacksonville, Florida, and Northeast Florida. Here are some of the bundled systems that they're participating in. Excuse my tongue twisting there. There are also some other models that they're working with right now I've learned about. A little bit about Brooks Health for a moment. Brooks Health is an interesting system. They're unaffiliated with any upstream provider. They're not part of a larger health system. They're a freestanding, multiple setting post-acute care system. 2 IRFs. Their flagship is the 153-bed hospital in Jacksonville. They also have a 40-bed inpatient rehab unit with Halifax and Daytona. They have 2 SNFs. They also have a home health agency, 32 outpatient centers. They're not-for-profit. They're kind of like a mini Kindred, if you will. Kindred is a big national player. This is very much a local player, but has all the post-acute assets. All right. It's been a very early adopter of bundled payment, and it's participated in both Model 2 and Model 3 BPCI models, and it's also acquired the waivers that are needed. You got lots of the financial model and gain sharing involves. I should just simplify here for the interest of time. They have considerable amount of gain sharing across the different players in the bundle. And the financial opportunity has really been on the post-acute side, because that's where most of the cost variation has been. All right. What I think is really interesting is their whole care management and coordination system. Particularly, they have a longitudinal care plan called PRAISE. They assess the person, have risk alerts, have patient interest identified, social factors, and the expected plan of care. You have 4 care navigators that also make home visits as needed, all right? And also a lot of in-home support right away after the patient is discharged from a post-acute setting. There is a phone call made, a follow-up, and another phone call made every 7 days. They also use what's called mobile therapy, which I think is kind of interesting. What's the idea behind mobile therapy is the idea that a patient, once they go home, and if something goes is not good or needs a special attention, what will happen is instead of initiating a home health visit, what may happen is that Brooks Rehab may send one of their therapists and say, please stop at patient so-and-so home on your way home or on your way into work. And so as to avoid triggering a home health episode, if you will. And what I find remarkable about that is that under the previous system, you couldn't necessarily do that because you wouldn't get paid for it, all right? But now, under bundled payment and with the savings that you get under bundled payment, you can redeploy your resources to pay for this kind of intervention. All right. They also do a lot in the use of looking at patient risk for readmission and for other issues, and they have a number of different risk scores that they use. And I'd like to spend a little bit more time on this, but in the interest of time, we will not. But to say that they do a lot of risk profiling to determine what kinds of patients need additional intervention, especially after they leave the system. All right. At the core of their system is really the care compass, all right, which is kind of like a live dashboard which absorbs data from all the EMRs and of all the different components of their post-acute system. All right. So, and what's remarkable about this is that they keep a whole number, they keep information on a lot of different dimensions about the patient. In addition to the 3 sets of risk scores that I've mentioned, they also look at a lot of other issues: prior function and function status, their allergies, their other vitals, their labs, their meds, any other medical issues. And all this results in a composite and weighted risk score, and all patients are then ranked, all right? And once they are ranked, what they do is that they have a dashboard where patients are color-coded: green, yellow, or red, all right? And much the way that you see here, all right? And that's a signal. If the patient goes into the yellow zone or into the red zone, it immediately will trigger additional interventions and possibly a home visit or a stop or calling the patient back into the facility or an outpatient setting or whatever the case may be. But it will trigger an additional intervention. Then also what's interesting, I find that this care compass is really, shall we say, the heart and soul of how they organize and how they manage patients over the course of an episode and beyond, for that matter. Programming is done by 3 full-time IT staff, and they're always improving this particular system. A lot of different quality metrics are involved, but the heart and soul of what they do is in the data analytics area. They have an in-house data science department that's comprised of 6 doctoral master's level staff representing research, finance, and data management. And they also mine both clinical and Medicare claims data. All right, this is the leadership team. I mentioned earlier Debbie Reber is one of my principal contacts in terms of learning about the system. She's also the one who's in charge of the whole Care Compass system. I've learned a lot through all of this, the importance of an organizational culture that values innovation, the use of technology, and they have really been able to reduce both their own cost and Medicare spending considerably and be able to redeploy those savings, as I mentioned earlier, for other kinds of interventions that otherwise they might not have been paid for under the previous system. And at the core, as also mentioned too, the really importance of data analytics and mining both clinical and Medicare claims data. All right, I'd like to just end with this statement by Michael Porter. He gave a talk several years ago at MIT here. You can also see it on YouTube. He said, innovation and value are less and less about the science and more about how we deliver care. And I think that's very, very true, and that's where health services research comes in. So with that, I would like to conclude and say thank you. Did we want to take any questions or not, or later?
I think for the sake of time,
okay.
we will save our questions. Please jot down your questions For our panel at the end of the day, we will have the opportunity to ask questions and ask for clarifications. But thank you so much for that excellent session. To start us off, so I want to introduce our next speaker, which is Dr. Joanna Bellin. She's Senior Director of Quality Analytics and Performance at the UPMC Wolf Center. So welcome.
Thank you. Hello, everybody. So I feel so privileged to be here, and thank you for that great introductory talk. I think it kind of sets up well for this talk because I work on the bottom half of that iceberg, and I really agree with a lot of the things that Dr. Zhang had mentioned. So I think we can get into some specifics on some of those, so that'll be a nice segue. So today I'm going to talk about who I am and why I'm here. I feel like a lot of you guys know each other and probably don't know who I am and why am I up here speaking. I'm going to talk a little bit about some healthcare quality definitions, measurement, and kind of improvement that we work on at UPMC, where I'm from. And then give a few examples of projects that I'm working on that might have some relevance for the rehabilitation folks here. So, who's Joanna Bellin? So I love the overview in the previous presentation because I am data analytics, finance, health services research, and health policy. I actually did my undergraduate in this very building in management information systems and finance at BU. I worked for a number of years in risk management at GE, and then I went on to a healthcare consulting business that worked with bankrupt hospitals, which was a really exciting environment. I went back and got my PhD in health services research and policy because it seemed like the financial management approach was really rearranging deck chairs on the Titanic sometimes. So I got a degree in health services research focused on organizational theory and change management, and really have thought about kind of the contextual factors about how do we really change healthcare. And then after all of that training and experience, I feel like I was slightly set up to take on healthcare quality, which I just love the complexity, and it's been a really fascinating journey so far. So I work at the Wolf Center at UPMC, which I would consider as quality operations. We're not really researchers, although I have a research background. I think I try to inform what we do with health services research, but we're really in the guts of like a lot of the things that Dr. Zhang mentioned. So these are all the things that the Wolf Center does. We do kind of traditional clinical improvement, boots on the ground improvement work. We're in charge of patient safety, regulatory, infection, patient experience. These two are my boxes. I work in performance programs, so CJR, MIPS, all the value-based purchasing models. We'll get into that alphabet soup. And then I oversee a quality analytics team. So this is like a boring organizational chart, but I feel like a lot of places don't have org charts, and it's kind of cool to see how does this all work. So this is my department. At UPMC, we have a little over 40 hospitals now, and growing every day, it seems like. Over 5,000 physicians, and then we also have a network of inpatient rehab facilities, skilled nursing facilities, home health agencies, et cetera. And I really service all the different specialties and service lines across the health system. So I actually work with a lot of surgeons, obstetricians, hospitalists, and then rehab professionals. And I have to say, you guys are one of my favorite groups, so I feel very lucky to be here and learning more about what you guys are interested in, what you're looking at. But what we really do is we have physician quality, hospital quality. So we just submitted our MIPS data last week through ECQM. It was exciting. We also have the abstraction folks that are pulling data out of the health records to do all those CFS quality metrics that are feeding into our data systems. This is an interesting space. I also oversee many of our clinical registries. We participate in the Society for Thoracic Surgery, the NISQIP General Surgery Registries. We're going to participate in the APTA registry. Jerry's right there. And I think that's a really great opportunity. This is my favorite source of data. The clinical registries for thoracic surgery, they collect 1,800 variables for each surgery. And you can really get at risk-adjusted quality outcomes. It's amazing, extremely resource intensive. But I think with natural language processing and other technological advancements, we'll be able to get to that in many other specialties. So that's really exciting work. And then I also oversee a quality data and reporting system. These guys are more IT folks that are building these live dashboards, bringing together all these data sources to do exactly what Dr. Zhang was mentioning. So when I think about healthcare quality, again, I work across all specialties, and I don't think rehabilitation is any different. These are my 3 favorite definitions, although there's many different ways to define quality, and it seems like the scope of what I'm responsible for is constantly growing. But I like these. They talk about safe, effective, patient-centered, efficient, and equitable, doing the right thing at the right time. And then I like UPMCs. This is our Wolf Center. We talk about compassion and supportive and effective environment. And so when I think about organizational theory, you have to have a good environment, you have to have the right people there, they have to care about what they're doing, and then you have to do the right thing for the right patients at the right time, and you have to have ways to measure all of that stuff, which is really hard to do. But I like the 3 quality outcomes that you talked about, like the outcomes, the experience, and what was the third? Patient safety. And safety, yes. And I'll get to that too. Like, I totally agree. So here's like, when I boil down like all of these programs that I'm responsible for, these are my like top 11. We had the 9 and now we have 11 things, but. So these are the performance measurement programs that I think about, and this is interesting alphabet soup. So we have all this pay for reporting, so the inpatient quality reporting, outpatient. We have our MIPS quality reporting, ACO quality measures. Then we have all these compare websites. There's star ratings for all the different facilities. We have private payer programs. US News hospital rankings, very important. Leapfrog, I should have added the Joint Commission on here. Everybody's got their own measures. And I think what I really boil it down to is these 11. And they're kind of like the Maslow's hierarchy of quality. We start off like, did you kill them? Did you hurt them while they were with you? And then we get into like, did they really need to be here? Did you do what you were supposed to do? And then we kind of get into these process adherence measures, like did you do the right thing? Did you at least like do their diabetic foot exam? And then I feel like this space is where the rehab professionals are so far ahead because you guys have thought about the functional assessments. You're already deep into the patient-reported outcomes. These are the outcomes that I think are important. It's like, are they better? Shocking. And then I think patient experience is a huge space. My health system has recently taken on improving patient experience for a variety of reasons. And I think this is a really hard needle to move. And I think it comes down to like, are people doing the right thing? Do they feel good about it? And are they making the patients happy? So these are my 11. And when I think about how they map onto what's currently out there in public quality reporting, I've included like several different settings. And I know later on there's a session that talks about measurement across settings. So I won't steal anyone's thunder. But when I think about kind of the hospital, the inpatient rehab, SNF and home health, hospital, like their functional outcome, the only one I could find was like vision after cataract surgery, which is really specific, but I was like, at least they have one. But when you think about home health, you guys have been measuring in the rehabilitation space, like many other things like movement, getting out of bed, bathing, less pain. Like, why aren't we doing those functional outcomes with surgery? So it's really interesting when I think about the different ways that the settings are measuring quality, how it's different. And I think that there is this convergence where people are starting to think more aligned. The Impact Act, I think, is going to help improve this. And we probably should be measuring like all of these measures across all of the settings. And I think there's a lot of opportunity to do that, especially with bringing together data sets. So this is my data sets. This is probably the most exciting slide for some people in here. It makes me very excited. So we use Cognos and Health Catalyst for our business intelligence. Those have both a front end where clinicians can see our dashboards and reporting, and then they have a back end where we build together these data sets. So basically, all of these data sets have a primary identifier key, which is either like the unit, the patient identifier, the physician identifier, et cetera. And then we can use all of these data sets together to say, like, did the billing affect the patient experience? Did something that happened in the lab affect readmission? So it's really great. This is like where we're bringing together the analytics. So I think when I thought about that type 1 and type 2 data, this is the billing data. These are our kind of standard billing metrics. The electronic health record, I think people talk about EHR data a lot. It's really messy. This is where you're like getting into power forms, like everyone's doing their own power notes and like what are the measures you get from that, like the vital statistics. But this is really exciting data, and I think this is where I spend most of my time like trying to wrench it out of my EHR team. I'm like, give me more data, because I think there's a lot of opportunity here. I think this is also where the Fitbit data and the remote monitoring data is eventually going to fit in there to do a lot better measurement. And then we maintain we have our own SQL server with these like oddball data sources, which is our patient experience, our infection data, and then a bunch of quality stuff you don't need to worry about. Then we have Riskmaster, the registries, our ancillaries, and then bringing in the operational data. So this is really what makes me able to do my job. So then I just think about, like, again, I work in the quality improvement space, so whether you're thinking about PDSA, Kaizen, Six Sigma, it's kind of all similar type structures, but this is really what my center does, and our data helps support the quality improvement across our health system using data and analytics to provide that feedback loop. So I'm going to talk about 4 different project examples that we've worked on, and these are more from the data and analytics point of view, but I'll also touch on kind of what the improvement strategy was as well. And like I said, I haven't really done as much work saying, like, what is the role of physical therapy in this, although we're getting to that in many of these studies. But hopefully these examples are helpful to think about on the health system side. How are we thinking about things? How are we using data? And then hopefully we can engage more health services researchers, because if you noticed in my org chart, I have 3 statisticians and 2 people to do all of my research and kind of doing the studies piece, and everybody else is just doing sort of operational data collection. So I like to rope in researchers when I can. So the first one I'll talk about is our CJR bundle. So we were one of those 34 MSAs that were required to participate in the bundle, and now I don't have to go over the specifics of what that means, because we just heard about it. So our issue was, when we first got our data from the government, we were spending too much money in this space. And primarily in the post-acute settings, we were in the red. At the end of the year, we were going to have to pay the government money back. So, like, because it wasn't optional, there was a really big push to, like, say, we need to do better in hip and knee replacement, and particularly in the post-acute space. And I think one of my favorite quotes in parts of this was, we had this sort of lovely but crotchety orthopedic surgeon, and at the end of it, he said, he's like, I don't like to admit this, but it really was the government was like telling me how to do my job, and it was really effective. So I think this has been one of the most transformational pieces of legislation and activities for our system. So thank you, Obama. So our hypothesis was, can we make changes in the pre-surgical and acute spaces that can affect and reduce our post-acute send? And the challenges here, like these are all like, there's cost challenges, there's process adherence, there's readmissions. You have to think about balancing those complications, the patient experience, because there's a lot of counterbalancing measures that could affect our quality if we would do the wrong thing. And so very briefly, our system had these 8 different interventions. There was a steering committee set up. We hired some orthopedic navigators. We enhanced our patient experience, or I'm sorry, patient education to manage expectations of where you're going to go in the post-acute setting. We developed some reversible risk factor stratification so we could know ahead of time where these folks should be going. We don't have the care compass yet, but I love that idea and I want to build it. Maybe I'll talk to you afterwards. We also started contracting with preferred post-acute partners that were really skilled in providing services for our hip and knee replacement patients. We developed an ED U-turn process to avoid readmissions that were unnecessary. And we, most importantly, I think, increased our reporting transparency. So I'm not going to go through all this, but this is one of our improvement specialists' wonderful depiction of all of those activities showing change across the system. And this is our dashboard that Dan from my group built. And it brings together billing and EHR data. It's bringing together infection data. It brings some of the OASIS and the skilled nursing facility data. We have cost data in here. You can see these tabs across the top. This is showing kind of a snapshot of like, what does one hospital's quality metrics look like? You can drill down into by physician to see, is your length of stay longer than others? Is your readmission rate longer than others, et cetera? The orthopedic surgeons went for total transparency. Everyone can see how everyone is doing. They're a very competitive group, and I think that was a really effective strategy as well. Like, it's created some very healthy competition on our hip and knee replacement patients. And then I would be remiss to say we've also done a lot of work on PROS collection, which has been challenging, but I think extremely fruitful. We also use, so this was one of our pre-intervention evaluations, and I think this is a piece of where health services research really helped with this intervention from the health system and operations side. So this is one of my statisticians made a multi-level Heckman-Probit regression model. Hope I got that right. And basically, we were trying to figure out from the beginning, like, what were the factors that were causing discharge to SNF or excessive length of stay beyond 3 days? Was it the hospital? Like, is it the culture of the hospital? Is it the physician? Or is it patient-level factors? And then we had these random effects of patient-level factors as well. So we controlled for these latent variables. We looked at these variables to say, how are they influencing discharge to SNF? And there's like many different outcomes, but this was the most shocking model. So each of these lines represents a different hospital, and we showed that it was really the hospital, not the physician, that was causing these discharge to SNF. And it was kind of a duh response, but I feel like most health services research is really just validating the duh response. And this hospital right at the top was across the street from a skilled nursing facility where many of the physicians worked. And part of the culture of the care management there was to send all of our female, older patients, everyone was going to a SNF. And like, you could have figured that out, but people start pointing fingers, and I think health services research was able to help us skinny down and say, like, this is a hospital cultural issue. Let's address this. And it kind of helped diffuse some of the finger pointing, and we have since been able to alleviate that issue and get people to go where they need to go. And so this somewhat ugly graph is our end of the day did it work or not? And you can see on here, this is the different post-acute settings. So we had inpatient rehab started out pretty like 15% down to 5%. We had skilled nursing facility started around like high 20s. We're down in like the low 20s, 15% range. And then home and home health on the up trajectory. And we actually made money in the first year. So, so that was a really great outcome. And I think there was a lot of activities that went into this, but it was really a cultural change and a group effort that was really positive and had some influence of health services research. And I think another interesting thing I'll point out is we actually shifted from having primarily nurse-driven home health to primarily PT-driven home health. And so I'll say like my next study on this is gonna look at like, were the PT home health more effective, less effective? What was the effect of the prehabilitation? What was the effect of the education? So we're working on that data now, and it will probably be another multi-level Heckman whatever model, adding in many other factors, and so stay tuned for those results. So our second study that I wanted to talk about was around the PROS data. So we've now been collecting our who's and our who's. We've been collecting it for actually a bit of time before this, before CJR, but now everybody's collecting it, so we have a good amount of data. And our orthopedic surgeons and rehabilitation specialists are thinking about like, eventually they're gonna wanna use this data. The government's gonna say like, not only did you collect it, but did you make a difference? So I think in a very forward-thinking way, we're trying to understand, are there patient populations for which the pros are different or looking different? Like what are the patient level factors that are affecting the change in the patient-reported outcomes? We have a lot of different projects thinking about patient-reported outcomes, again, working with Jay and others from our rehabilitation school. And I think this was just one of our first studies to say, like, what are the patient-level factors that affect change in patient-reported outcomes? And so you can see we're bringing in different data sources from the billing data, from our surgical data, from our EHR, et cetera. And this is kind of the main outcome. And I just have to say this was presented at the Academy of Orthopedic Surgery as well. But the main outcome was that our African American population was starting out significantly lower in the baseline and had a similar improvement trajectory, but never reached the white and the other patients. So that's a really interesting finding. And similarly, you can see almost a similar pattern. The Medicaid patients started out significantly lower and had a similar trajectory, but never reached the same level as the commercial and the Medicare patients. And I think as we think about interventions going forward, trying to address some of the disparities and some of the differences in our populations, this will be really important to think about how are we really affecting the outcomes for different patient populations versus treating everybody the same. So very early work, but this again was a multi-level beta regression model like that we used health services research methods to help try to improve the care of patients in our system. The third project I wanted to talk about was a home transitions model. I think a lot of you guys have work in the post-acute space have thought about different transitions models. There's like there's a Cochrane review, there's many meta-analyses around transitions. And I think some of the pieces that are still unknown are what are the effects of the different clinicians and what they're doing. And so this was a pretty traditional care transitions model. They were trying to reduce hospital admissions and ED utilization for our patients that are transitioning from the hospital to home health. And we thought that by using some predictive modeling to say which patients are at medium and high risk, can we improve their care and reduce those readmissions. And this has been proven in the literature that this is an effective model, so we're trying out in our pragmatic setting without a research grant. So our quality challenges for this one are readmissions, process adherence, and function. And so we're looking at our patients at medium and high risk, and then this is the intervention. There's a lot of different pieces of the home transitions model. They're deploying nurse practitioners, they're involving social work, they're doing some enhanced therapy, although we didn't yet evaluate that piece. They're thinking about medication safety, et cetera. And so in this model, I think one of the interesting things about this is the data source. In addition to kind of the typical billing data like the comorbidity index, the diagnoses, we were also looking at income, ADL assistance, teachable caregiver at home, live alone. These were all extremely significant variables in our model. And I think pulling in some of that OASIS data, some of that social data, can really help models like this to identify which patients really need help. Because a lot of my surgeon friends like to look at the vital statistics and try to predict readmissions. But I think if you don't have these kind of variables in your model, you're going to have a hard time really identifying which patients need the most help. So this program showed that for our medium readmission risk patients, the home transitions program on its own was shown to be no different than usual care. And what we did was we used propensity score matching to match our health plan patients with our fee-for-service patients across all of these different variables and found the ones that received the intervention versus didn't. And then we found that the health plan patients that were part of this intervention, when matched with these other ones, had a reduced probability of 30-day and 90-day readmissions when a nurse practitioner and social worker was involved. When they weren't involved, no difference. So I think using that statistical methodology to tease out which piece of this intervention is making a difference was really helpful. And I think that could be an approach also when you think about teasing out like the effect of a physical therapist, the effect of an occupational therapist could be really helpful. In the high readmission, it was only reducing the odds for 30-day, but that makes sense because this wasn't a longitudinal program. These guys in the high-risk group had a lot more needs. The last one I'll talk about is telemonitoring for CHF patients. This is a very early study, so I apologize for the outcomes. They're in very rough format. But we're using Vivify. This is where you send a box with a tablet, or you can send a program to somebody's phone to understand or to do remote monitoring on their vitals, and it sends alerts to practitioners to say, this person's heart rate is elevated, or this person has a change in this vital statistic that might affect their CHF outcome. And so what we wanted to do was evaluate was this remote monitoring for our CHF patients making a difference? And the challenges they were thinking about was, again, readmissions. They were also thinking about mortality. We have an interesting mortality rate with our CHF patients. And then process adherence. Are people doing the right things at home once they leave? And so all of the patients in our intervention group received some version of Vivify, and we're part of a home health. We're part of a home health group, and then we used, again, propensity score matching to compare to patients that were not in telemonitoring. And I'll say that the propensity score matching, we not only looked at kind of the typical comorbidity index, et cetera, We also used EHR data to look at their vital statistics in the hospital. Were they clinically similar in cardiovascular health, et cetera? And these very early outcomes that we're still trying to add some more variables into are showing a significant reduction in observation readmissions, but an actual increase in our low and high risk groups for 60 and 90-day hospital readmissions. And we think that that is because when these alerts fire for the clinicians, the home health nurses are then sending folks back to the hospital. And so we've been thinking about, if that's the case, like what else could we do to intervene in the home versus sending them back to the hospital? So this has been really helpful to think about this program and kind of the programmatic elements and how we can improve it. But interestingly, we've also seen a significant reduction in mortality, which is one of our, I would say that US News and World Report's main driver is mortality. And this has been a very interesting topic for our system to think about, what does our 30-day mortality look like? And this program seems to be helping. Maybe they're coming back to the hospital, but it's improving the mortality statistics overall, which, again, these are very early findings, and we need to do a lot more validation on this, but it's an interesting approach that's using data from an app, matching it with EHR and billing data, and really giving us some great reflections on this program. So just to list off some other projects and ideas for data sources, other things that we've been working on is kind of activity-based costing data in healthcare to think about the cost of care. I think a lot of people look at claims data. If you look at the financial side, we use, actually UPMC developed and then sold to Health Catalyst a proprietary activity-based costing model, and that allows you to see the health system data on cost, which is really interesting. So we've been trying to use that to say, what is the cost of a VTE or what is the cost of C. diff? And that's been really fascinating, again, controlling for differences in patients to say, what is the true cost to our health system of providing that? And once we move to capitation and other models, it's important to know how much is it costing you. We've also done a lot of work thinking about employee engagement and patient experience. I couldn't think of a really great example for that we've done that's kind of a rehabilitation relevant, but I think that this kind of data is really interesting. We have a My Voice survey that our institution uses every year to evaluate employee engagement, and we also have gobs of patient experience data that we're using to evaluate the patient view of their experience in our health settings. And we did a correlation analysis just between employee engagement and patient experience and found that our low engaged units have really low patient experience, or significantly lower patient experience. Again, it's the duh finding, but when you show that data to our health system leaders who are being incentivized on patient experience, they're like, maybe we should do something about improving the experience of our employees. We've also been thinking about risk adjustment for surgeon performance, but I think, again, this could be applied to other settings. One of the things that's been of real interest to me is video assessment and using, working with some of our folks from the enterprises, which is sort of venture capital IT component of UPMC. They've really been using machine learning to look at videos and say, like, did the surgeon do this? Did the surgeon do this? And providing kind of structured data from videos into models to say, are people doing the right things? Is that having an effect on outcomes? We're pretty early on, but we've already shown that video assessment of surgeon activities in laparoscopic cholecystectomies is related to OR time. And that's been really exciting to think about. How could we use video assessment and the data from like what people are actually doing to predict quality outcomes. So I have a lot of interest in continuing in that space. We also use a lot of our CMS QRUR. If you're not under the iceberg, you may not know the acronym, but it's the utilization reports that we get about our physicians from the government, and our Medicare spending per beneficiary reports, which we combine with our health plan data to understand, again, from the payer side, what does the cost look like. And we are actually theoretically applying for an ACO in July, and my little one's gonna be showing up then, so I have to get that application going. And we're also been thinking about what additional bundle opportunities, given the success of CJR, that we wanna apply for as a health system. I think we're hoping that we can rope our ortho and rehab friends into some additional bundles there as well. So we've been using the CMS data that we get to help evaluate some of those opportunities. So my closing thoughts are, I think that many of the national quality programs that apply to all the different settings, they really make up those 11 quality metrics that we've been trying to improve across many different programs across UPMC, and I'm sure across all of your health systems as well. And that really can help inform the work in rehabilitation. There's a lot of different data sources, a lot of different ways to measure things that I think are really exciting. I think there's a ton of opportunity for health services research to help people like me in the health system really do good program evaluation, maybe not across the entire country, but I think in small health systems, it's important to evaluate, are these programs that we're doing, are they working? And also the risk adjustment, the predictive analytics, exactly, how are you saying which patients should be part of this? How are you saying, did it work for this patient? And I think using some of that more nitty-gritty data with our claims data is really important. And I think everyone in this room has the skills to do that, but there's not a lot of people in my position that have access to people that can do that. And then I also, I have my Shadish, Cook, and Campbell, quasi-experimental design. We don't often have the opportunity to do RCTs in a health system, but we can do quasi-experimental design galore. I can propensity score match. I think about it every day. It's my, I have that book out on my desk every day. It's amazing. And then I think also connecting across disparate data sources. I love the CLDR idea, bringing in new different, what if eventually we could bring in video monitoring across the country, those vital statistics, the motion statistics. There's so many different data sources that I think combining across large systems would be really helpful. And you can do that through, we have a pretty, UPMC doesn't have a data warehouse, but we have that framework I talked about. But you can do that in Excel. It doesn't have to be complicated. I think people overcomplicate the data. There's a lot of grunt work. I worked in Excel for the beginning part of my career. And I think starting small and building up is really important. And I think we can all achieve that. So that's all I got. Sure. Yes.
Who would you think, we have a microphone? I'll just repeat the question. Oh. Who do you think would be your peers among, you have UPMC, yeah, you have UPMC, and among, who would you consider to be your peer organization doing similar kind of work?
Yeah, so I know that, I think we have folks from Intermountain here that are doing that. I know the Armstrong Center has done similar work. I think there's groups in, obviously at Johns Hopkins, there's groups at, I think that many of the Boston hospitals that are doing it. We're a large integrated finance and delivery system. There aren't that many, most of the country is not that. But I think that conveners, when I think about the the CDRNs, like the clinical data repository networks. Like people, you can create a virtual UPMC. Like you don't have to be one entity to do this. Like if you can get a few health systems to work together and agree to share data and have the health services research support behind doing these analytics, I think you could achieve that without having like the formal infrastructure. My group is 60 people, but I think the people that are actually doing this work, there's 6 of us. A lot of those people are abstracting our EHR. They're like doing those clinical data registries. They're not the ones that are like doing this work. So it doesn't need to be a large group, but I think the collaboration is really important. And that's hard to get people to like say, we're gonna collect the same data, we're gonna report the same data, et cetera. But I know it's been done. Tony's PCORI grant's doing that, like, so it's possible.
Great presentation, Joanna. And kind of related to that, I mean, most of the people in here are researchers, so what would your advice be to them as far as trying to work with the healthcare system and kind of bridging that gap for a healthcare system that's interested in doing work quickly, you know, showing quality quickly versus a researcher who wants to, you know, as the other extreme, wants to look at everything so, you know, particularly. So if you have any comments as far as that, I think would be helpful for the group.
I think there is so much opportunity. I think there's often this tension between like the applying for the grant timeline, getting the grant, and finally starting, like, and people think like, oh, I have to wait to start my intervention until I have a grant 2 years later. There's an opportunity to do pilot work. And I love that CoStar is funding pilot work. So you can work on these small interventions. If you find like a quality manager in a hospital, like they probably have a boatload of interventions that they would love to evaluate. And then if you're able to spread those to a larger network or a larger system, that becomes the grant. So I think getting in early to say, like, we will help you evaluate your program, we'll help you spread your program, is like a good way to establish a relationship, and then use that as the springboard to apply for that grant later on when they want to spread something. That might be a little pie in the sky, but that's how it works at UPMC, that all that joint replacement work was mandated. I think also these government programs, if you have a system that is facing a new BPCI, if you have a system that's joined an ACO, and you go in and say, we'll help you evaluate it, they're gonna be like, wow, like, that's really great, because they don't have the resources to do that. It's pretty rare. So I think offering to help with the evaluation, if you can mesh the interests of the health system with your research interests, there's definitely a lot of opportunity.
Colleen Keegan from Boston. I'm interested in how you got the surgeon buy-in for looking at laparoscopic deviation, numbers of moves with outcomes, and how you could describe that.
Sure. So one of we have a, the Center for Robotic Training. So we have lots of Da Vinci machines, and there's a center there that has looked at kind of QSUM training curves, and they found that for efficiency in the OR, and I attend our surgical services operation committee, they're really into efficiency in the OR, because the more you can turn it over, the more surgeries you can put through there. So they really want to have efficient surgery. So OR time is our kind of interesting outcome, but I think that you could also look at quality outcomes, et cetera. And so we had a group that has been doing kind of robotic training, and because of that, they were interested in doing these video assessments. And then we were able to say, all right, the robotic surgeries are not happening very often. What's a surgery that's happening really often? Lap choles. And so we kind of took this very small work that we'd done in robotic hernia repair, and we mimicked it in a larger program, again, the spread, and have done that same evaluation. Now they're interested in looking at robotic hysterectomies. They're thinking about other settings. They're like, this is a great way to improve efficiency and also improve the surgical skill of our surgeons. So I'm happy to talk about more detail, but that's basically how it happened.
Gerard Brennan, Intermountain Healthcare.
Hello.
Hello. Before I ask my question, I just want to say thank you for your excellent presentation, and Dr. Dujon. I mean, what a kickoff to unbelievable meeting, and I hope this CoStar thing never, ever goes away. It's just unbelievable. So my question was, and I was the 3 trend lines that you showed, okay, across time, and how you reduced, what was it? What was the?
We reduced inpatient rehab use, skilled nursing facility use.
Okay, so my question related to that was how you were doing interventions all along the way. You were intervening with different types of methodologies all along the way. And how long did you measure the impact of those interventions? Or was it just like, oh, maybe it's this, and you'd input something, and then it just all happened to culminate and go down? Is that how it worked?
I think that, and this is where I had that little like stay tuned on our next analysis, because we've been sifting through a lot of data. I don't know if we're ever going to be able to tease out like when we were faced with the bundle, and I don't know if you remember that huge diagram of all the different interventions that we did. Those kind of like many of those happened at the same time. So we established our preferred skilled network. We established patient education. We gave physicians feedback on like, you're sending a lot of people to the skilled nursing facility. All of those happened at the same time. And this is the same thing with like the home transitions. Like, can you really tease apart like which was the most effective? And I think that becomes very challenging in a pragmatic environment to say like, was it really the contracting with the post-acute provider, or was it the education and patient expectation setting? And I don't think we'll be able to ever say like, we're just gonna have to say, this group of activities created this outcome. Right. Like you would have to almost randomize and be like, in this setting, we're only gonna do contracting, and in this setting, we're only gonna do education, if you really wanted to tease that out. And I just don't know that that's pragmatic. So I assume that as more systems have these approaches, that we can use the benefit of large N size to maybe do some of that teasing out, but that's what I got now.
One other quick question. On the Hoos and Coos example for race and for payer, was utilization controlled?
We did in the beta regression model. They are doing the Hoos and the Coos at all of their post-acute visits. So I don't know if you remember, but there was a baseline, and then we had buckets of like 3, 9, and 12 months. And we don't have utilization metrics of like how many times they went to therapy, how many times, which would be a really interesting addition to the model. Yes, this is exactly why I'm here. I need more ideas on how to like, but yeah, so we have like the kind of trajectory of like the different time points with the patient-reported outcomes measurement, but I think utilization would be an interesting addition to that.
If you're talking about race and disparities,
yep.
That would be really
Yeah, and I think actually that would be a really pragmatic thing to look at, because I know that there's interest in like what interventions could we do to kind of help close that gap. And maybe it's like working on different access models and things like that. That's great.
Thank you so much.
Sure.